You're listening to Medscape's In Discussion series on secondary hypertension, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Marwah Abdalla. Dr. Abdalla is a cardiologist, cardiac intensivist, educator, and scientist with expertise in hypertension, sleep, and cardiovascular health. She is the Florence Irving Associate Professor of Medicine at Columbia University Medical Center, where she serves as Director of Education for the Cardiac Intensive Care Unit and co-director of the Columbia Hypertension Center. She served on the writing committee for the 2025 American Heart Association, American College of Cardiology, Multi-Society High Blood Pressure Guideline. Relevant disclosures can be found with the episode show notes on medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for U.S. healthcare professionals.
Hello, I'm Dr. Marwah Abdalla. Welcome to the Medscape In Discussion podcast series on secondary hypertension. Today, we'll discuss renal denervation and its incorporation into the 2025 American College of Cardiology, American Heart Association Multi-Society High Blood Pressure Guideline, including when patients with resistant hypertension should be referred to a specialist, how candidacy for renal denervation is determined within a multidisciplinary center, how clinicians should counsel patients about expected blood pressure reduction and risks, and what procedural safety and follow-up look like in real-world practice. First, let me introduce my guests, Dr. Herbert Aronow and Dr. Syed Ahsan. Dr. Aronow was chair of the SKY position statement on renal denervation for hypertension, which covered patient selection, operator competence, training and techniques, and facility recommendations. He is medical director of heart and vascular services at Henry Ford Health and an interventional cardiologist with over a decade's worth of experience in performing renal denervation for uncontrolled hypertension. Dr. Ahsan is a vascular medicine specialist, section head of vascular medicine, and hypertension lead within the cardiology division at Henry Ford Health. He is a part of the advanced hypertension program and specializes in resistant and refractory hypertension, including team-based evaluation and integration of device-based therapies such as renal denervation. Welcome to the Medscape In Discussion Secondary Hypertension podcast.
Thank you so much, Dr. Abdalla. It's really great to be here.
Thank you, Dr. Abdalla, for inviting us to this. It's great to talk about something you feel passionate about.
So I'll start by saying we really can't talk about renal denervation without first talking about resistant hypertension. And as you both know, the 2025 ACC-AHA Multi-Society High Blood Pressure Guideline defines resistant hypertension in two ways. Either as blood pressure above goal, despite treatment with 3 antihypertensive medications with complementary mechanisms of action, including a diuretic at maximally tolerated doses, or blood pressure at goal, but requiring 4 or more medications. So, Dr. Ahsan, I'd like to start with you and walk through the beginning of a patient's journey. From your perspective, at what point in the treatment pathway should a patient with resistant hypertension be referred to a hypertension specialist?
Well, I think that's a great question and a great starting point. Since you've already defined resistant hypertension, I'm going to not talk about that. But the referral should really occur when there is therapeutic inertia, when you feel that you're not moving the treatment along anywhere further from where you are. So, for example, if a blood pressure remains uncontrolled despite thoughtful medication optimization, there's a suspicion for secondary hypertension, medication intolerance, or even evidence of end target organ damage, the referral is appropriate. And the key is that referral should not be delayed until someone has had blood pressure for many years. So you want to do it sooner than later.
So, when you see these types of patients, what are the key steps that you're taking to confirm resistant hypertension, even before renal denervation is even discussed?
So that is where the long pathway comes in, right? Patients are first evaluated in the hypertension clinic. Confirm true hypertension, resistant hypertension, medication adherence, secondary causes need to be evaluated, and then, of course, sustained blood pressure control. To make sure that we do this right, we need to confirm proper measurement techniques, maybe perform ambulatory blood pressure to eliminate white coat hypertension, or home blood pressure monitored with a structured process, assess adherence, optimize pharmacotherapy, make sure that there is no secondary causes, such as now we are asked by the guidelines to check for primary aldosteronism renal artery stenosis, CKD, sleep apnea, and endocrinological disorders. So these cases need to be run by us, completely checked back and forth. Then once we are kind of close to the point where we think this person needs a further intervention because whatever we're doing is not enough, nephrology, endocrinology has given their input if need be. And only then, after that structured evaluation, does renal denervation enter the discussion.
And given that resistant hypertension carries substantially high cardiovascular risk, are there specific phenotypes you prioritize for referral? For example, patients with target organ damage or something else?
The short answer is yes, but thoughtfully, always within a structured evaluation framework, right? So resistant hypertension is just not a number problem. It's a risk multiplier. These patients have substantially higher rates of MI, stroke, heart failure, and significantly high cardiovascular mortality associated with it. So when I see a resistant hypertension patient who is already demonstrating end organ damage, that really heightens my concerns. The phenotypes that makes me pause and potentially accelerate my evaluation, or when I see an LVH on an echo or CKD happening, concomitant diabetes or stroke, significant albuminuria going on, or PAD. These are your patients where every millimeter of mercury pressure matters. And that said, I mean, you don't skip the line. The structured workup still takes place, but you kind of accelerate that process. There is a sort of an urgency and intensity to follow up at that point. And of course, the more proactive we are with adjunct options, including renal denervation, with the potential benefit, even a modest drop of 5 to 10 millimeters of mercury pressure, sustained reduction can result in meaningful absolute risk reduction in this population. So, yes, I pay close attention to the phenotype, but always within the framework of the discipline guideline based evaluation and shared decision making process.
Fantastic. So, speaking about shared decision making, you're both part of a multidisciplinary process in a hypertension center. So, can you sort of walk us through once you've confirmed true resistant hypertension, you've optimized therapy, and now you're thinking about referring? How do you determine the ideal candidate in a multidisciplinary way to send to Dr. Aronow for further evaluation?
So the pathway still is long, even though there's a long pathway we have traveled. So once we have confirmed true resistant hypertension and optimized therapy, the key word here would be discipline. Renal denervation is never the next reflex step. It's a structured transition within a multidisciplinary framework. At our hypertension center, the patient remains under the care of the hypertension specialist first. We document the uncontrolled pressures, the medication adherence, the guideline-directed therapy, diuretics if we can get them on board, and then evaluation for all the secondary causes like we talked about, lifestyle changes. And then typically what we would like to do is run this by with our interventional colleagues whom we are going to be referring this for potential RDN. So we discuss the phenotype, the risk profile, the images we have taken, and how the blood pressure has been over time and what kind of anatomy this person has. Once we have kind of checked all those boxes and those safeguards are in place, we have the patient transition to a discussion for RDN at that point. So the idea is it's not a self-refer to the proceduralist. It's a process and pathway where discipline and checking those boxes becomes really important.
Fantastic. And Dr. Aronow, when that patient finally reaches you, can you walk us through what you're assessing from the interventional standpoint to determine if this patient is a good candidate for renal denervation?
Yeah, I really appreciate that question. So I think you've heard a lot about what happens upstream, what should happen upstream, right? The ruling out of secondary causes, the assessment of whether the medical regimen has been optimized. And then I think when the patient sort of checks all those boxes and is open to the idea of a procedure to treat high blood pressure, and I think that's really important because most medical conditions, right, we don't necessarily have to treat with a procedure. So that concept may be challenging for some patients. But when they are open to that idea, I think that's the right time to then refer them to a proceduralist who can walk through really the granular details of what that means. Probably the best person to have that conversation is going to be someone who actually performs that procedure. Before we know, as a proceduralist, whether or not a patient is a candidate, there are certain anatomic criteria that we'll need to confirm. We'll want to make sure that There's no significant narrowing from atherosclerosis of the kidney arteries, no fibromuscular dysplasia, no significant renal artery aneurysms, no recent renal artery stents. And of course, we'll want to understand the underlying renal function because while there isn't a threshold at which it becomes a contraindication, at which renal denervation becomes contraindicated, we do know that in clinical trials, we really have not enrolled many patients who've had estimated glomerular filtration rates under about 40 or so. So once we ascertain all of that, then I think we can have that conversation about here's what happens if you continue down the path of medical therapy and lifestyle intervention alone. We know that there's some risk to you of all the conditions that you've just heard about, heart attack, stroke, kidney failure, heart failure, and so on. And that if we can reduce the blood pressure, even if it's not to normal, but just simply by 5-10 millimeters of mercury, we know we can substantially reduce the risk of those events. Typically, I'll walk a patient through the procedure itself. Today, it involves gaining vascular access through the common femoral artery. In the coming years, I'm sure it'll be possible to perform this from the radial arteries. The radial arteries are the more common access point for coronary procedures these days, like diagnostic coronary angiography and percutaneous coronary intervention. And we know that the risk of bleeding and in general complications is lower with that access site. The technologies available today aren't designed in a way that we can use them from the radial arteries yet, but they will be. We know that work is underway. So I walked them through the idea of access through the femoral artery, which again isn't unique to renal denervation, but how we get into the vasculature for a whole host of procedures. Explain that we would start by taking pictures to augment what we may already know. Perhaps they've had a duplex ultrasound or a CT angiogram or MR angiogram. And so now we're going to do an invasive angiogram. Explain that they may feel some warmth when the dye goes in, but as the dye fills the aorta and the renal arteries and any accessory renal arteries that may be present, we'll get a really important lay of the land and understand if maybe there were any contraindications on that list I mentioned earlier that weren't evident from the duplex ultrasound or some non-invasive angiogram. If not, typically we will take a catheter and we will selectively engage it into the ostia of each of the renal arteries and advance a tiny guide wire into that vessel. And over that guide wire, we'll then advance whatever technology we're using through the catheter, either ultrasound or radiofrequency energy, to ablate or permanently damage the kidney artery nerves. I'll explain to patients that typically the procedures can take up to about an hour, that we'll sedate them pretty heavily so that they don't feel the denervation procedure, and that we may not see an effect immediately. Sometimes it can take months before we know whether the procedure has been fully effective. And so we typically instruct them not to change their medications unless their blood pressures are running particularly low. We may or may not place them on adjunctive medications like an antiplatelet agent, an aspirin, for example. And then we'll typically follow them up on a routine schedule that I'm happy to speak to.
Fantastic. I'd love to go back to this idea that cross-randomized sham-controlled trials, there's sort of variability in the expected magnitude of blood pressure reductions. It's great to hear that you upfront tell, your patients that you may not see something immediately. But can you tell us a little bit more how you frame that conversation? Because for some, there might be a possibility of non-response and their medication burden may never decrease. How do you upfront talk to them about that?
I think the issue of non-response is really important and has to be discussed in that first meeting. This is not a perfect procedure, and it's very difficult to assess how effective the procedure has been at the time that we're performing it. In that way, it's very different than many other things I do. If I put a stent in someone's coronary artery, I can assess right then and there whether it was effective, whether I am happy with the result. That's not true for renal denervation. I know I've delivered the energy for the prescribed period of time and in the prescribed way, but I don't really have a good way. There's no feedback loop telling me that I effectively denervated. I'm going to have to wait and see over time. And as many as a third of patients, depending on how you want to define it, may not respond. Sometimes in some studies, it's been an even higher proportion of patients who haven't responded. And so I want to make sure that patients head into this eyes wide open knowing that there's a chance they may not respond and we may have to utilize other non-procedural means to try to lower their blood pressure if this isn't effective. That said, most patients, meaning the majority, will respond and will get enough of a blood pressure reduction that even if it doesn't mean coming off blood pressure medications completely, it should mean a substantial reduction in their risk for adverse cardiovascular events.
What do you think general clinicians should understand about procedural safety when it comes to renal denervation, specifically about, access site complications, renal artery injury, but also effects on long-term kidney function, including the risk of post-procedure renal artery stenosis? Because as you mentioned, the EGFR becomes an important, classification, at least in guidelines right now, where there is a minimum threshold. So I'd love to hear a little bit more about that.
Yeah, I think that the anticipated complications and the frequency of those are going to be important both to referring physicians and also to the patients, of course. The good news is that in the trials and even in the large real-world registries in which we've followed these patients now for at least 5 years, we are not seeing significant rates of complications. Now, if we walk through what types of complications might occur, let's just start with the beginning of the procedure, and that's vascular access. Because we're entering an artery, that means the risk of bleeding is higher than if we're entering a vein. And because it's a bigger artery than the radial artery, it's going to accordingly give a higher risk of bleeding than one might get if they were doing a radial artery access type procedure. That said, these days, I think our techniques have evolved in general, not specific to RDN, but just with arterial access, use of ultrasound and micropuncture needles. And then, of course, means for attaining hemostasis at the end of the procedure, suture-based and plug-based, other types of procedures. We see pretty low rates of vascular access complications. They won't be zero, but they should be very low. What do I mean by that? A few percent at most, probably less, given that this is a relatively small bore procedure. We do procedures that require much larger sheath sizes. These typically require 6 or 7 French sheaths. You might be performing a mechanical circulatory support or structural heart intervention with anywhere from a 14 to a 19 French cannula or device. And so it's a spectrum, obviously, the risk of bleeding, but I think this procedure lies very early or low on that spectrum of risk. The risk of things like renal artery dissection from engaging the vessel with a catheter, or from placing a guide wire in it, or perforation from either the device or the wire, are also exceedingly low, well below 1%, well below 0.5%. If we look at the randomized trials that have been published, and those patients have been scrutinized very thoroughly, both of the time of the procedure and over time, we're really not seeing substantial complication rates that would make us want to shy away from performing the procedure. And it's important to note that that's among a cohort of operators that weren't all necessarily used to spending time in the renal arteries. These were not all endovascular specialists. Many of them were interventional cardiologists who were proficient in coronary artery intervention, but hadn't really done much when it came to renal artery intervention. So I think that's important because it means it's translatable. The skill set is translatable, and it is translatable at a low procedural risk.
Great. Let's talk follow-up and longitudinal care, and I'd love to hear both your perspectives. Dr. Aronow, I want to just follow up regarding after the procedure, how frequently you actually see them after renal denervation. Can you touch a little bit about there? And then I'm going to ask Dr. Ahsan a couple other questions.
Yeah, when it comes to follow-up, I think, the truth is with more procedures, of course, we never know. And so we tend to probably see people more often than we need to. And then over time, as things evolve over the years, my guess is that people back off a little bit. Right now, what we have are clinical trial protocols on which maybe we would base our typical follow-up. So in clinical trials, we would see people at 1 month, 3 months, 6 months, and a year, and then yearly thereafter. We would be assessing their blood pressure and their renal function at those time points. At 6 months, we would typically look at the renal arteries. And again, you had asked about renal artery stenosis, and I don't know that I spoke to that before, but the risk of that is also under 0.2%. It's very uncommon for that to occur. But that should be assessed through some kind of non-invasive imaging. Typically, a renal duplex ultrasound will suffice. If the results of that are equivocal, one might proceed with an MR angiogram or CT angiogram, depending on local expertise. And then, if I didn't already mention it, estimated glomerular filtration rate, so assessment of kidney function over time. The good news there is that we're not seeing any decrement in renal function over time. There's naturally some decrement in people who have hypertension, who may or may not have some degree of underlying chronic kidney disease. We're certainly seeing no more than one would expect, and in some cases, less than what one would expect.
Great. Dr. Hassan, I'd love to hear from your perspective what the follow-up and longitudinal care looks like.
Well, first of all, we need to understand that the renal denervation procedure is one of the armaments in our toolbox. So it's a long-term process. So when we start seeing these patients post-op, we want to see them sooner than later in the first week, 2 weeks. It's all, again, is protocol driven. We want to make sure that the site access, as Dr. Aronow was mentioning, is appropriate, is clean. There's no hematoma. There's no other complications that you can get from site access. And after that, the patient comfort, pain level, kidney function, renal function needs to be monitored. And once we are done with the first 3 to 4 weeks and we think everything is okay, then the patients need a more close monitoring of medications, because a lot of times patients who have undergone these procedures, they have this maybe a understanding that my blood pressure is not being cured. And we need to make them understand this is not a one and done kind of procedure. We do need to continue our medications. We do need close follow up. So we would like to see them at intervals of 1 month, 3 months, 6 months, 12 months, and then repeat imaging as needed, repeat BPMs if needed. Most of the time, if there is the home blood pressure monitors, if they have been calibrated with the office monitors, they're adequate to give us the information we are looking for. But many a times, there's a lot of discrepancy between the two, and you may need to do an ambulatory monitoring. But like I said, majority of the times, frequent follow-ups, lab work, urine test, and medication optimization, I should say, not changes, is required over a long period. And usually within the first 3 to 6 months and a year, you will see things settle down.
And since they're still probably seeing both the interventionalist and use a hypertension specialist and maybe even seeing their referring clinician, I'd love to sort of ask you, when adjusting antihypertensive medications throughout this period, who really should be doing it? Should it be all people whenever they touch a clinician, whether they're an interventionalist or a hypertension specialist? Or do you think that it should really be, still directed under one?
Well, that's a great question. And the reason why I think that's a great question is because by this time, there are a lot of chefs in this kitchen. And there
Yep.
is the primary care doctor who initially referred, there may be a nephrologist involved, interventionalist who has done the procedure, and then you got the hypertension specialist. Ideally, what we would like to do is have our playbook ready for these patients. So, whoever is initially following these patients post procedure should be able to, write a comprehensive plan down that if this happens, we would do this. If this were changed, we would go this. If there's a medication we want to withdraw, this medication should be withdrawn first before the other medication. So a structured plan should be in place. Once that plan is in place, at that point, it shouldn't really matter who is making the decision because you're all working off the same playbook. And that is the most critical aspect of this, is that we want everybody literally to be on the same page. So who should do this? Ideally, the plan should be set out by the hypertension specialist, and then everybody else should chime in and make small moves. But there should be one person who should be answerable for the plan. And at this point, I would say that the hypertension specialist is probably that person who should take the responsibility. And they may choose to talk with other doctors and make changes as they go through, but it all should come down to the same page. If it
Hmm.
doesn't, then you have these, stepping on toes problem where you're making changes while somebody else has made some changes. And that should never happen in any day, not just in hypertension, but in any place. But especially in this case where there are so many things moving at the same time, a written playbook is very important.
I also want to ask, when do you decide that the person's actually a non-responder? Dr. Arno mentioned earlier about a third of people may not have any response. So if you're following them over, 6 month, 12-month period, when do you finally say maybe they're a non-responder?
Well, again, I'm the kind of person who doesn't believe in non-responders. They do exist, but I don't believe in them. So I believe everybody responds some degree in somewhat. Ideally, what we would like to see is optimization of medications, lifestyle changes. I'm a big believer of that. And if all of that has come in place and 3 to 6 months have passed and you really have not seen that needle move, then you may start thinking this person has not really responded. But I wouldn't throw the towel in until a year has passed, because that would be the real timeline for us to show any changes. Again, we have seen through other trials come through that the blood pressure changes ever so slightly over the period of time. And over a period of 5 years, 10 years, we have seen sustained decline in pressures. So, if you're looking at very methodically, we may not see the big picture. But if you step back and see what the timeline has been, I would say that majority of the people will start showing, even if they're small number declines, but they continue to show those declines through and through.
Fantastic. So let's look ahead. Dr. Aronow and Dr. Hassan, you're both in this field for a long time. What's on the horizon in terms of novel approaches to renal denervation and any potential benefits for renal denervation being studied beyond blood pressure control?
It's a really exciting time in the field. There are only two devices right now approved in the United States by the FDA for use. They're both indicated to reduce blood pressure as an adjunctive treatment in patients with hypertension in whom lifestyle interventions have been trialed and antihypertensive medications have as well, but together haven't adequately controlled blood pressure. So I want to make that clarification. It's not just resistant hypertension, it's also uncontrolled hypertension in those scenarios. But there are other innovations that are under development, under investigation. So, for example, there is another ultrasound device in addition to the one that's approved that is being studied. There is a device where alcohol can be injected into the wall of the renal artery, again, in an attempt to ablate the renal artery nerves. There's work underway looking at denervating multiple organs, so not just renal artery sympathetic denervation, but also simultaneous hepatic artery sympathetic denervation. And early data to suggest that that combined approach, at least for radiofrequency energy, might be better than just renal artery alone. And then finally, there are other ways of denervating other than inside out. In other words, other than through the use of a catheter. I was in the operating room today as part of a clinical trial that we're doing, a first in human trial that Dr. Ahsan is actually the site principal investigator for, looking at extravascular renal denervation using radiofrequency energy, where one of our urology colleagues performed a robotic, minimally invasive procedure to access the renal arteries through the retroperitoneum and wrap those arteries temporarily with a device that delivered radiofrequency energy in multiple locations, and then remove that device and, of course, sew the patient up. Now, that's a very early stage of development and investigation right now, but we're seeing some numbers that are really profound, an order of magnitude greater than what we're seeing with catheter-based approaches with that laparoscopic approach. And so it might be that we have a toolbox, and when someone walks into the office and we've tried everything and ruled out secondary hypertension, and maybe their blood pressure is 20 points higher than we'd like it to be, well, maybe we grab a catheter-based therapy. But maybe when they're 200 over 110, we know while we can lower blood pressure, and it's important, and that even though that will lower their event risk, we really want to try to get them closer to our goal, closer to, let's say, 130 over 80, that maybe something like laparoscopic RDN will play out. And again, it's too early. There hasn't been a pivotal trial to look at the efficacy and safety. So I'm not advocating that as a therapy yet, but I am saying it appears to hold promise. And there are probably many other potential device therapies that will as well. So like I said, very exciting time for us. I guess my final comment would be there are also other applications being studied, and we've seen some in heart failure, but perhaps the most exciting that I've seen have been around atrial fibrillation. AFib is a really common condition, and the threshold for offering AFib ablation is much lower today than it used to be, given that the devices are safer and more effective. It turns out, and we know this from randomized trials, if you're a patient with AFib and you get an AFib ablation, if you get randomized to renal denervation versus sham on top of that AFib ablation, if you get renal denervation, your risk of AFib recurrence is actually substantially lower. So I wouldn't be surprised if in years to come, it becomes pretty standard to get AFib ablation with renal denervation.
Mm-hmm. Fantastic. Dr. Hassan, would you like to add more to that?
Well, I think Dr. Aronow has covered a lot of those fields. And so there's one thing we need to understand about all research that takes place in the world of hypertension. technologies need to be vetted, technologies need to mature, technology needs to be launched and deployed. But at the heart of all this technological processes comes the basic, medical management, which is very, very crucial in these cases. But in terms of procedures, we have all that. And then we have a lot of exciting medications coming through, which are blocking different pathways. And we'll see some of the exciting ones come through in the following years. We have certain ARNI blockers and so on and so forth. So yes, procedures are coming in the storm, but the medications are also trickling in. So we should keep an eye out for that.
Fantastic. So, in closing, I'd like it if you can both think about 2 key takeaways you want clinicians to understand about renal denervation. Dr. Aronow?
Number one, small reductions in blood pressure translate into large reductions in risk of adverse cardiovascular events. People shouldn't be misled by a reduction of 5 or 10 points, even if it doesn't get a patient to goal, and think that that isn't really important for that patient. It's still critical. Number two, hypertension, and more specifically, renal denervation, are team sports, if you will. It is so important that we take a multidisciplinary, multi-specialty approach here, whether we're talking about a device therapy, lifestyle intervention, or pharmacotherapy. And so that means we need multiple perspectives from the care team. It also means we need really good coordination and communication and handoffs, whether there are procedures in the mix or not.
Fantastic. Dr. Ahsan?
Well, if I would be leaving clinicians with 2 important points, my first one would be make sure that the resistant hypertension is true. That is the most important thing, that we somehow label a lot of different hypertensives, including your non-compliance, people who have secondary hypertension, and we label them as resistant hypertension, and they go through advanced procedures and they don't benefit. So the safeguard is the system. Every patient should go through the system, and just because we know this patient for 5 years does not mean that all the boxes are checked and all the T's are crossed and the I's are dotted. So develop systems in the hospitals that will allow them to safeguard these patients from going through procedures when there were other avenues of treatment present. So that's number one. Number two, realistic expectations. I think Dr. Aronow touched upon this when he was talking about this. This is critical. Just because we are not at goal, like less than 130/80, does not mean that the procedure did not work or the medications are not doing their job. A small amount of reductions in blood pressure results in significant relative risk reduction and absolute risk reduction in different outcomes that we're interested in as hypertension specialists, including all end organ damage. So safeguard systems and make sure the patients knows what they're getting into, and let the doctors know what they're offering also.
Well, thank you both for your expertise and for helping clarify how renal denervation for the treatment of resistant hypertension should be evaluated and implemented within a structured, multidisciplinary framework. Thank you for tuning in. Please take a moment to download the Medscape app to listen and subscribe to this podcast series on secondary hypertension. This is Dr. Marwah Abdalla for the Medscape in Discussion podcast.
Thanks for listening to Medscape's In Discussion Secondary Hypertension podcast series with our host, Dr. Marwah Abdalla. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out medscape.com or the Medscape app for show notes, links, and more information on secondary hypertension.